You want to do that?
Yes. Hi, everyone. Everybody mute their their computers. And I'm going to introduce our speaker for today, Harold Girado, MSN, RN, Vice President and Chief Nursing Officer at Baptist Hospital of Miami, is a key member of the executive leadership team. He is responsible and accountable for the leadership of and direction of patient care throughout the organization. Integrating and coordinating a patient-centric nursing strategy, ensuring that delivery of high-quality and cost-effective healthcare is consistent with the mission, vision, and values of Baptist Health South Florida. Harold ensures effective business and clinical operations for all the inpatient nursing units, as well as rehab services for acute, inpatient, and outpatient services. So without further ado, I would like to introduce you to Harold Girado.
Good morning, everyone. Thank you for having me. I'd like to take this opportunity, a few minutes this morning, just to share with you the state of affairs for the healthcare organization, specifically Baptist Health, Baptist Hospital, which is we call it the mothership of the organization out on Kendall. We currently have 9 hospitals throughout we call it the South region and the North region. We have Bethesda, North and South, and Palm Beach, as well as we just affiliated with the North. And we also have, obviously, the sister hospitals down here in the South, which you are, I'm sure, very familiar with Homestead Hospital, Doctors Hospital, Baptist Hospital, South Miami Hospital, and Mariners in Monroe County. We also are building a new hospital for the Middle Keys in Marathon, with Fisherman's Hospital, hopefully slated to open later next year. So as all of you know, as business men and women, we've had to deal with this pandemic earlier this year. We saw a peak in March and April, which, looking back now, it's a little blip on the radar to what we're dealing with today. And I hope just to share some light with some of the ongoings within the hospital. There's a lot of information out in social media and the news, and I just want to be able to shed some light on what's actually going on within the hospital and the healthcare system. Julie, if I'm able to share my screen, would that be okay? Because it's disabled.
Yeah, let me just add you as a co-host. Now we'll let you.
All right, let's see. Okay, here we go. So, like I said, we've been dealing with this since beginning of the year. Started, out in Asia and China, and the way the virus worked its way, east or west, and took hold here in the United States. We are a free country, so people moved around, and this provided a perfect breeding ground for this virus to spread. It hit pretty hard New York, and back in March and April, when things were pretty much falling apart, for lack of a better term, in New York, we tried to do our best here, which obviously affected all of you and your businesses, shutting down. And I think we were able to control it somewhat. But unfortunately, it didn't go away. I'm going to share some numbers with you that show the stark contrast to what we saw back in March and April. Let me share the presentation. Okay. So these are the numbers of daily cases for the entire United States. Back in late March and early April, mid-April is when we saw our peak. And as you can see here, it was about 3,500 cases. Well, as of early July, we had doubled that number of cases in the state of, in the United States, with over 70,000 cases. And this is per day, not on a monthly basis. This is a total per day. The difference that we saw here in Florida, as you can see here, we were averaging at the peak, we had about 2,500 cases. In Florida, that's been a 7-time increase from our peak in March and April. We had several days of 10,000, 12,000. We shattered the record that New York had with 15,000 plus cases 2 weeks ago. And this is a very concerning trend, specifically because back in March or April, when we had closed down, folks were very scared. The unknown, they didn't know what this virus was about. Everybody was staying home. Even the people that were sick were taking home remedies and not coming to the hospital to seek care. So at that time, even though we didn't know a lot about the virus and people, obviously it was affecting the older population, and those folks were getting very, very sick, the hospitals were empty. So we had a lot of resources available at our disposal. We had a lot of nurses, a lot of respiratory therapists. We had a lot of equipment because our hospital was at 50% capacity. We weren't doing surgeries. We weren't doing procedures. We were holding on all that. And then you saw in the month of May, we had a sustainable number of cases that we can manage. And we did do that. I think there were a few things that happened, obviously, that were unforeseen. You started having the unrest in the community. People were going out, not practicing social distancing, not wearing their mask, which has been shown and proven to help thwart the spread of the virus. And one specific note, that some people have a misunderstanding. The masks that we wear really don't protect us. It protects others from us. So when I wear a mask, I'm actually protecting you. And if you wear a mask, you're actually protecting me. But that alone is not going to help. You also need to keep your distance of 6 feet or more, which does help. So when those riots and those people gathering in the streets started happening, a lot of those folks obviously were in close contact, not wearing masks. And this is just my theory. I don't have proof to say that, but that's when you started seeing the numbers start increasing. Usually when you see things like this, whether it's a holiday or social gatherings, you don't start seeing the impact for about 2 weeks later. And that correlates with the numbers that we're seeing. I think it was a perfect storm because, right after those gatherings, you started having the major holidays, the Mother's Day, the Memorial Day, the Father's Day, and 4th of July. And, down here, especially in South Florida, a large Hispanic, community, we all like to gather. We all like to be with our friends and relatives. And it's just part of our culture. And, again, this is my theory, and I think that did play a part in these numbers starting to rise. The concerning thing for me as a chief nursing officer and what we're seeing, from the infection standpoint is that although our mortality rate has increased and it's still impacting, that age group of 69 to 75, the number of folks that are seeking higher acuity care, which we call step down, is rising. Right now, those numbers are about 25 to 35% of the folks that are coming into the hospital seeking higher acuity care. The good news is that those folks are recovering. 75% of the population that is infected, that's over 75%, are the ones that are actually causing the mortalities when they get to the ICU. Let me go to the next slide. So this is and if you look at the slide, you start seeing the numbers that actually match, and you see the trends going in the same direction. What you're seeing here is actually for Baptist Health South Florida, and this is a daily number. You can see again, back in March, we started seeing the peaks here at 54, and then we had a steady number in the months of April. And then, it was something that was a steady number coming in that we could manage, but then you start seeing back in June and up to July where those numbers dramatically increase. Now, these numbers are taxing the healthcare system. We did divide it here in Miami-Dade and Palm Beach County. You're not seeing those numbers in Palm Beach County. Most of the admissions, and I'm sorry, just to give you a little bit of feedback, what you're seeing here are numbers of admissions into the hospital, not number of patients that are positive. These are patients that are coming in, being tested, and having to be admitted into the hospital for care. So the large majority of the numbers that you see here are specifically that are admitted are happening in Miami-Dade County. Baptist Health, which has the largest number of beds, obviously sees the larger and the lion's share of the admissions. And the peak that we saw was on July 12th, where 135 patients were admitted to the hospital. Now, this is a daily count. So you look at from July 2nd through July 14th, and over 100 people a day are being admitted to the hospital for seeking care for the virus. Okay, we have other folks, and the phenomenon that we're seeing now that we didn't see back in March and April is that people no longer can stay home. They put off seeing their doctors, they put off getting their procedures or surgeries, they put off starting their chemotherapy because they were scared. They no longer can do that. They're at a point that they're much sicker than if they would have come in back in March or April. So the patients that we're seeing that come in through our door are very, very sick, requiring a higher level of care, again, taxing the healthcare environment and taxing our nurses and our respiratory therapists and our physicians. So that's where we are today. Some of the things that we are doing, we have a certain finite number of employees, of staff that can help, which no longer meets the demand of the patients. It's gotten to the point where we've had to stretch our staff to be able to take care of these patients. Unfortunately, we don't have the luxury of closing the door and saying, hey, we're full, we can't let anybody else in. Everybody that comes through our door, we have to treat. We try to treat these folks and send them home. Unfortunately, many of them require a higher level of care, and we have to admit them to the hospital to treat them with antibiotics, IV therapy, and medications to help them get better before we can discharge them home. So this is a slide here that shows the number of the admissions at Baptist Hospital alone, and not the system. These are numbers that we get from our strategic planning. They have different ways of looking at historical numbers and mapping out what they think it's going to look like, and they've been pretty spot on. So this is the month of July. You can see, and these are our patients that have the diagnosis of COVID-19. So back on July 4th, we have 799 licensed beds. That means that from a state requirement, those beds are licensed by the government. Not all of them are staffed. We currently have the ability to staff about 650 of those beds. And again, that is stretching our staff. And we try not to stretch our staff too much, because obviously then we don't want things to fall through the cracks, especially with this type of patient population that requires a higher level of intensity of care. So back on July 1st, we had a census of about 152 patients with the diagnosis of COVID. And as the month of July went on, you can see these numbers drastically increasing. So today, I believe, is July 21st, and our number is about 314 that we assumed that we were going to have. Actually, yesterday when we did this slide obviously was done on earlier in the weekend. That 314 was really yesterday. So this trend is going a little bit higher than what we actually anticipated, which is concerning. We track this because we have to see a week out. We need to prepare. Obviously, getting things ready in a hospital takes some time and the resources that it takes to do this. We've had to convert units. We cannot mix the patients with the general population, so we have to have units that are specific to taking care of the COVID population. Again, if you mix these patients, you run the risk of cross-contamination, and that's the last thing that we want to do. So converting these units takes a lot of resources. We need our facilities folks to check the air handlers and the air conditioning and make sure that the amount of airflow that goes through there is enough to keep the air clean. We have to make sure that we have the right equipment in the rooms. We have to make sure that the staff have, the supplies that they need. The medications are a little bit different. So we usually try to get ready a week in advance, emptying out the unit. and getting it ready for the next surge of patients. So currently today, back in the beginning of July, we had 2 units that were COVID. Our units are pretty large. They're about 50 beds each. And we had about 2 units that were dedicated to our COVID patients. Today, we're about 50% of our hospital is for taking care of these COVID patients. I mentioned earlier that the concerning piece is that a lot of these folks, especially when compared to back to March and April, we had a phenomenon where patients that came into the hospital requiring care either needed just, oxygen for support and IV therapy, making sure that their organs were hydrated, because this virus attacks the organs. And when you get to that multi-organ failure phase, it's very hard to bring those folks back. We obviously have medications and treatments that we've seen that have worked. Steroids seem to work on these patients very well, as well as remdesivir. I'm sure you've heard of that drug a lot in the news. Unfortunately, as of yesterday, we had run out of remdesivir and we hadn't received our next shipment. That causes a problem because patients that are on that treatment, once they stop, we stop being able to manage the virus. So, and then patients that need it are delayed in getting it. So that's another concern that we have, that we don't have the medication or the resources to manage this volume of patients. So every day we're waiting by the loading dock, hoping, crossing our fingers that shipment that's tracked to get to us. And it might sound bizarre, but it really is. We're just crossing our fingers every day to make sure that we get that remdesivir shipment so we can treat the patients that are currently on it, and we can treat the new patients that are coming in. We are working with our pharmacy reps. Unfortunately, we are at the level that we have to decide which patients get our remdesivir and which patients don't. Obviously, we in the United States, we don't think that we've ever had to do that. But we are at a point that we have to leverage who is the right patient to get these medications. So patients that are in multi-organ system failure and that are intubated, right now we're not using those medications on. We're using them on folks that we feel very confident that we can get those patients turned around quickly. So just back to the screen here. Today we're at about 314, which is about 50% of the bed capacity that we have. Our concern is that going into the weekend and into early next week that we're going to run out of beds. And then we have to start making decisions on what we're going to do. So we're already making plans to close off part of our emergency department to be able to treat these inpatients. And then we have to, start discussions of maybe putting a tent outside the hospital to treat and street many of these folks. And treat and street, I'm sorry, that's the term that we use. That's for patients that come into the emergency room. We treat them and then we send them back home. So, very concerning. We have a great team at Baptist Health. We're on calls every day figuring out how we're going to do this. We have great collaboration with our sister hospitals. We're transferring patients, to the hospital that has the capacity. That brings up another set of dynamics. Some patients, are comfortable going to the facility of choice. But many have been very understanding that, this is necessary for them to start their treatment right away. The last slide just, shows and depicts a little bit more of what I've been talking about in terms of our forecasting our bed capacity. Again, these patients are becoming more sick before, and we've learned a few lessons. When we first started here, we thought with our intensivists that the earlier we intubated these patients, the better it was for them. We can keep their lungs inflated with high percentages of oxygen. But what we quickly realized in doing some research is that once you put these folks on a respirator and intubate them, it makes it very hard to get them off. So we're employing different strategies to try to not intubate these patients closer, which now makes them at a higher level of care. So where we saw patients being admitted to a med-surg unit, now they're being admitted to a intermediate unit so they can get high flow oxygen. There's this equipment that we use, it's called a BiPAP, which is a mask that they wear around their nose and mouth and forces high flow oxygen into the lungs. It's a less invasive approach, but it does have, it's shown promise and helped avoid getting patients intubated. But this slide, what it shows is that the need for high acuity ICU beds will extend past what we can do at Baptist Hospital at the beginning of August. So if we can get this thing turned around and get this this curve to flatten and start heading in the other direction, we might be in a different conversation come August. You know, we are in conversations with our state representatives, figuring out, you know, there is the convention center, which fortunately for us has not been taken down. From my understanding, that is still a possibility to use as a field hospital. We were hoping that we didn't have to use that, but if the numbers continue to go, we might have to ask help from the state to open the field hospital and at least take maybe the non-COVID patients there where they can treat those patients and they can go home. We are getting help from the government in terms of staffing, which is great. Those folks should be coming in next week. We're getting over 300 nurses. We're getting respiratory therapists. We're getting clinical partners. All these people are gonna be a huge help in giving our staff a break. One thing that I'm really concerned about is the well-being of our staff, not only physically, but emotionally. We have seen some post-traumatic stress signs in some of our caregivers, which is something that you only think would happen, you know, in the military, but the things that they're seeing and the things that they're having to deal with are a big strain emotionally. Many of you know we do have at hospitals a no visitor policy, especially on the COVID units. Which puts a lot of strain on the staff because obviously families want to know how their loved ones are doing. So we constantly have to be updating them, which is the right thing to do, putting them on video so they can see their loved one. And, you know, it's heartbreaking because some of these folks are dying alone, and that's something that nobody should have to go through. So I wish I had better news. I don't know if I did a good job of making this as peachy as possible, but I do think it's important for people in the community to know, you know, that we're here for them, and we're doing the best that we can. But we are going through some very difficult times, and we're not the only ones. You know, we are in contact with our local competitors, Mercy, Mount Sinai, the University of Miami, Kendall Regional. And they're on the same boat. We've even tried to move patients out. And again, you would think, you know, it's a crazy thing to do to move people with good insurance that pay very well and move those people out to a competitor. But right now, that's not our priority. Our priority is to make room so we can take care of the influx of patients. But unfortunately, they're on the same boat, and they're not willing to take our patients. They're actually trying to find where they can send their patients as well. So, you know, we're hoping that in August, you know, with this influx of staff coming in, we can give our folks a break. We can have the human resources to take care of these patients. So we're very thankful for our board members that picked up the phone and called their state representatives and got them to, you know, not only provide support to Jackson Hospital, which obviously is our catch-all hospital for our community, and that's priority, and that should be number one, but to also have them support our local non-for-profit organizations like this hospital, I think it's going to help us tremendously. So I'll open it up for any questions that you might have. Again, I'm not a physician. But if I can provide some information or answer any of your questions, I'll be more than happy to do so.
Yeah, I have a quick question. Are you seeing the same kinds of patients that you saw before now, the elderly, or are you seeing a different kind of mix of folks that that require that top end care?
So the demographics has changed a little bit. We're seeing more of these 59, 50 to 67, 65 population needing and requiring higher level of care, meaning they need to come into the hospital. Many of those folks back in March and April we're coming in with symptoms, maybe fever, sore throat, a cough, but their vital signs, their blood pressure, their oxygen saturations were still very good. So we were sending those patients home. This go around, this wave, we're seeing those patients a little bit more sicker, where they require in-hospital admission and in-hospital stay. But good news is that in terms of mortality, that number for that population is still low. We have seen an increase. So if you look at mortality in terms, of a percentage, 75% of mortalities related to COVID are still in that 75 age or older. 25%, which is a jump from March and April, which I think back then was very low, was maybe 10%, is attributed to that, 49 to 65, 67 years of age. Again, many of these people have underlying health conditions, but unfortunately we have seen young folks with no underlying conditions somehow be consumed by the virus and unfortunately die. So that's a very small number, thankfully. We're still seeing the elderly be the ones at higher risk, but we have seen an increase in those 45, 47 to 65-year-olds having to be admitted into the hospital.
What would be your percentage of people that are no underlying condition that you just you were just referring to? What would be the percentage of people that come in perfectly healthy?
That detailed information I do not know. But in terms of demographics, I'd say admissions, looking at about maybe 25, 35% of admissions to the hospital are folks in that 47 to 65 range. Again, many of those are being discharged, but we're seeing a lot more of those having requiring admission.
Mm-hmm.
What is the average length of stay?
Good question, Richard. Back in March, I would say with about 5 days. Now we're looking at about 8 days. Now, the average length of stay obviously is an average. So we have patients, those that require ICU, we're seeing them there for at least 2 weeks. Because we obviously don't discharge them from the ICU once they require that higher level of care and they get better, then we downgrade them and put them back in a med-surg population until they're ready for discharge. So those requiring ICU level of care are probably closer to that 14, 18-day length of stay. But when you average it all out, we're probably about 8 days right now for COVID admissions.
Harold, what's the best thing or most impactful thing that we as either business owners or individuals can do to support the hospital system?
I appreciate that. We do have a lot of opportunities for our community. I think from a marketing standpoint has done a great job of getting out to the community. We do have a lot of urgent cares. We have care on demand. So we're trying to get folks that if they are seeking care for themselves or their children, to try to use one of those resources first. Obviously, if it's a heart attack or a stroke or a major vehicle accident, anything like that that's major, we want you guys to come to the emergency room. But we're asking folks that, if it's an earache or something like that, a fever, even a fever or cough, to try to use those tools before they tax the emergency room. From a business standpoint, I know it's very important to keep the business open. It's our livelihood. It's what makes this great community what it is. We just ask that if it's something where there's a lot of folks involved, try to keep as much as possible the people separate. If you're having meetings with your staff, do it via Zoom. A lot of folks are doing that, which has been very successful. One thing that we did notice in the hospital, where we started having a lot of our staff having to be quarantined because of an exposure, we had to close the staff lounges because, again, this is very, very spread out through the community. Some folks were infected through a family member or a friend, and then came to work. Obviously, everyone's wearing a mask at work, but you can't wear a mask to eat. And staff were congregating together, eating in groups of 5 or 6, and that's a closed environment. And we started seeing a lot of staff having to be quarantined for that. So if you do have staff lounges, you might want to consider, closing them, or just having, unfortunately, have people eating lunch on their own. And just having, the support of your folks to make sure that they have, the gel, the alcohol, wash their hands. If you have your bathrooms, make sure that you put signs up to make sure that people wash their hands. As simple as it may seem, soap and water kills the spore of the virus. Just washing your hands, not touching your face. These are simple things that if most people did, I think we'd be in a much better place. So, from your standpoint, stay at a distance from folks at work. I don't know if you guys have a mask policy at work. I think that's something that everybody needs to consider doing if they're not doing now. Sometimes it's hard to hold a sneeze, and if someone with this thing sneezes, you're going to have to close down your business, because nobody there is going to be not infected. So I think wearing a mask, social distancing, I'm sure you've heard this millions of times, but it's proven to work. And just wash your hands. That's going to save you. And don't pinch your face.
Does us? I know a lot of businesses have contributed to the hospital in terms of delivering food for nursing and medical staff. Is that something that is more of a pain in the ass, or is that something that's actually very helpful?
No, I think, it has to be, and thank you guys, those of you who have done it, the staff truly appreciate it. They feel the love, and I think that when they're having a rough day, that little card with their sandwich means a lot to them. The only thing we ask that it's an individually wrapped lunch, but that's something that we continue to have our local supporters bring to the hospital, and it does go a long way. It does make the staff feel appreciated, and it just makes their day a little bit better. So we are more than happy to take those donations, and yeah, again, that's something that makes them very, very happy.
Cool.
Do you recommend your staff do anything to protect their immune system? In other words, is there vitamins or medications that they can take? That I was told that I'm on blood thinners, and I was told that that's a good thing to start with, because remdesivir is a blood thinner. And I take vitamin D every day, and some other things, but are there any other things that you all recommend to your staff to be doing?
I think that, just like any other virus, before we go into flu season, people have their own remedies. People load up on vitamin C. Those are all good things for your body. I mean, I think that's something that you should do on an ongoing basis. So there's nothing specific. We're still learning a lot from how to treat and how to combat this virus. So there's no magic wand. In terms of blood thinners, we have seen in the mortality cases and some of the cases that we've seen that because of the multi-organ system failure, it does causes a reaction in your system to cause clots. So a lot of these folks have developed strokes and heart attacks because of the virus and what it does to the body. So we have heard of physicians saying, blood thinners are very important. I wouldn't recommend folks going and start taking, blood thinners without talking to their physicians. But what we do is when they do get admitted to the hospital, if they're not on a blood thinner already, we are putting patients on blood thinners to try to avoid these things from happening.
What about this doctor out in Texas that uses budesonide with a nebulizer, and he claims that he's got 100% cure rate with that? He calls it his silver bullet.
I haven't heard about that. I know Texas is another state that is seeing a huge surge. So he probably has folks lined up outside his office to get that type of treatment. We do use nebulizers. One thing we try to avoid nebulizer treatments because it's an aerosolized, sorry, I can't say the word, aerosolized procedure. And basically what it does is if you have a patient that's confirmed with COVID and you give them a nebulizer treatment, you're basically putting that virus out in the air. So a recommendation for you guys, if you guys know of someone that has asthma and normally takes nebulizer treatments, and for whatever reason is doing okay, but does have COVID and was confirmed to have the virus, make sure that if they do those treatments at home, that they do them in a closed room, away from family members and friends. And basically after they leave that room, nobody should be going into that room for at least 3 hours. Because the aerosolized treatment stays in the air for a good 45 minutes to an hour and a half. And if you walk into that room and you breathe it, you're going to get it. So, we try to convert most of these patients in the hospital to a meter dose inhaler, those things that you see around people taking for asthma treatment, so to protect our staff. Because if our staff has to go into those rooms while they're doing those nebulizer treatments, it exposes them it puts them at a higher risk for an exposure. So I haven't heard that treatment. That's something I'll have to go back and talk to our pulmonologist, but our physician meetings, I haven't heard about that.
It was on a national news in Texas, one of the CBS stations, but he said the inhaler doesn't work because what actually makes it work is that it's like taking a fire extinguisher and putting out your fire in the kitchen at the front door. You know, this goes right to the air sacs, and the steroid immediately immobilizes the COVID virus. Now, it's very interesting what you said. If you did use that, you better be careful not to have everybody in the room when you're using it.
Because to your point, it goes all the way deep into your lungs when you breathe in. Remember, you have to breathe out. So all that stuff comes out as well. So
Right.
if you have someone that has the virus and is taking these nebulizer treatments at home, they should do it alone, and they should do it in a room that is nobody's going to go in until it gets disinfected.
If you're interested, I'll look his name up here. It's an interview that was done on one of the national stations, but
I'd love to check that out and share with our medical staff.
okay. Y'all go ahead and talk. I'll tell you in a minute. I don't want to waste your time while I'm fumbling around with my.
Harold, given the information that you have and the wealth of knowledge that you have, what do you see over the next 6 months? If you were to make an educated guess or a prediction, what do you see happening over the next 6 months in terms of, the circumstances, hospitalizations, things like that?
So we thought, and we were pretty confident, unfortunately, that we were going to get a second wave, which we're in right now. But we thought that we would probably see that in the fall, late August, early September. It obviously hit much earlier. We are preparing because we think in October, late fall, early winter, this thing is going to get really bad. So I'm hoping that I'm wrong. And hoping that our experts and our medical staff is way off. But so far since March, looking at our predictions, and especially the predictions that we've done now through July, they've been pretty on target. So I don't think this is going to go away. I think eventually we'll be able to manage it just like we do the flu. But the key is a vaccine. Once they can get that vaccine, I think we'll be in much better shape. I think the convalescent plasma that you hear a lot about is promising. Unfortunately, it's very hard to get donors and matching donors. And there's only one organization, it's called One Blood, that we deal with. There's a lot of things that have to go in that. So there have been delays in getting folks that convalescent plasma. And convalescent plasma is basically a blood, part of your blood that we pull out for patients that have had COVID, but already has fought it and are feeling better. So those that have recuperated several weeks after their infection, we'll bring those folks back and pull the plasma out of their blood type and cross it, make sure that we have a match on the other end, and infuse that plasma on a patient that's sick. That seems to be showing some promise. But right now, the one thing that is really helping us significantly is that remdesivir and the steroids. It's working very, very well. It's making folks recover much, much quicker. And hopefully, we'll get some more things down in the pipeline before the fall season comes. But from our understanding, we won't have a vaccine till maybe end of the year, early next year. So we might be a little bit late in the game in terms of beating the rush to flu season. So we're concerned that come November, December, some parts of the country, hopefully not Florida, but we're going to be seeing this all over again at a much higher rate.
Okay, if you look it up on YouTube, it's Dr. Richard Bartlett on ACWT Texas interview 7220 on YouTube.
Okay, I'll take a look at that.
It's an interesting read. I especially would love to hear it from a medical person like you to see what you think.
Sure, I'll get back to you guys.
Yeah.
Okay, so any other questions?
I have a question actually. Is the damage that it causes to your organs, is that something permanent even after you recover from the coronavirus?
Yes, it's usually when we see this organ failure, we see it a lot in the kidneys. So these patients that have to get into the ICU are put on dialysis. But once the medications start working, once we can get the pneumonia out of their lungs and they recover, they're not on dialysis permanently. They do recover. Their kidneys recover. The liver is a massive organ. It takes a beating for many, many years, and it does recover nicely as well. Again, we've only been dealing with this for the last 6 to 8 months, so we don't know what the long-term effects are going to be. But these people are going home with all their organs, their electrolyte balance and working correctly. So we haven't seen long-term effects yet. So we'll know more of that in the years to come.
Okay, thank you.
All right, I think that we want to thank Harold. Harold, we really appreciate that you took the time. We know you're busy. I appreciate that you came talking to us and checking all these things. This is a very important subject. Thank you to bring again that we need to protect ourselves in order to protect our loved ones and our coworkers. We appreciate everything that you're doing for the community. Really, really interesting job. You guys are the heroes, and we really thankful for always for you guys. I don't know if anything to add, Julie.
Thank you very much.
Very well. Hopefully I can come back and present a much different picture, and we can celebrate, beating this thing, and I'll be happy to do that.
One quick question. Have you seen patients that come back with COVID again, that they had it like in February and then they got it again?
I asked that question to our chief of medicine yesterday, and we haven't seen, and that's like the $1 million question. Are we seeing people get reinfected? And we haven't seen that. So I don't know if other states or other hospitals have. We have had patients come back readmitted, but for other reasons. But we haven't seen folks that, it's difficult because even once you've recovered from the virus, you have this virus in your body and you're shedding that virus for weeks. So we've had folks that are feeling great, but when you test them 3 weeks later, they're still positive. And we don't know if those people are able to expose others at that time. But when you test their blood or you do the nasal swab, they're still testing positive, even though it's been a month since they were discharged from the hospital. So I think there's still a lot to learn from that. But from my understanding, we haven't had a lot of, I don't know of any that have come back that positive, then tested negative, and then were reinfected. We haven't had any.
But it is not contagious once you've had it. You're shedding it for weeks. It's not
correct. That's the part that we're still not 100% sure.
Okay.
It depends on the person, the viral load. It depends on how much viral load you still have, whether you can still expose others. But again, once we've always said, we've heard in the news, once you've tested positive, it's 14 days that this thing is actually able to be spread. So I think for that reason, and we've gotten promising news on that after those 2 weeks, you're going to be okay, and that's what we're going by.
Thank you, Harold.
All right, guys, stay safe, please.
Thank